I'm just going to start the meeting. So welcome to the January Health in Hackney. Online we are joined by Cllr Samatar and Helen Woodland. For those online in the chamber, we've got Richard Bull, Kirsten Brown, Cllr Kennedy, Cllr Oguzkanli, Cllr Patrick, Cllr Goldberg, Cllr Adams. I've had apologies, and Cllr Baffour has just joined us online, as has Sally Beavan from Healthwatch. Welcome, everybody. I've had apologies from Dr. Sarah Husbands, Janet McMillan, and Cllr Maxwell. Just going through the standard matters of housekeeping. It's a hybrid meeting, so for those online, please raise your electronic hand. Welcome to Chris Lovett, who's also just joined us. Please don't start conversations in the chat. We're being live streamed, we're being recorded. Members of the press may be watching, members of the public may be watching. For those online, please keep yourselves muted unless you're speaking. Please keep your cameras on, particularly when it's your item. And that is that. Declarations of interest. I don't think I have been notified of any. And so with that, we can swiftly move on. So we've got two substantive items on the agenda. One, in terms of primary care, access and quality, and two, cabinet members question time with Cllr Kennedy. We've left an hour for each. So I'm going to welcome Dr. Brown, who's a partner at Spring Hill and the Lawson practice, and also the primary care lead for City and Hackney, and also Richard Bull, who's the City and Hackney primary care commissioner. We've got a very helpful presentation. I don't know who was possibly planning on speaking first, and then I'll throw it open for questions. Kirsten.
Thank you very much, and thank you for inviting us this evening. As you said, I'm Kirsten Brown. I'm a GP. Can you hear me okay? Is that better? Brilliant. So I am a GP in Spring Hill practice, which is in the north of the borough, Stamford Hill, and I am the clinical lead for primary care in City and Hackney. And we've been asked to come to this evening to talk about GP access, so thank you very much for the invite. There was a pack of information that was distributed before. I'm not going to go through that pack. There's a lot of information, a lot of data in there, so too much to discuss for me to present, really. But I would like just to take a little bit of time at the beginning to give some context to this agenda item. And then really the most important thing is to open it up to discussion and take any questions and have a really open and honest discussion about the current situation. So I've been a GP in Hackney for nearly 20 years now, since 2004. It's a privilege to be a GP. I think it's an amazing job, which I love to do. It's a privilege to know my patients, to get to know my patients, to see them at their most vulnerable and at their most resilient from cradle through to grave. And I don't think there's any other job like it. But it is a job that is becoming harder to do. And I think that's for a variety of different reasons, which makes the current situation very difficult. To start with, we have a workforce crisis in general practice. There are not enough GPs in this country. In my practice alone, I would employ 3 more GPs if I could. We advertise and we just cannot recruit. And we are certainly not the only practice in City and Hackney. It's quite widespread. We also know that this is a countrywide problem. We also find that the complexity of patients that we are seeing is becoming much greater. This is because of a variety of reasons. People are living longer and they are living with long-term conditions. We are seeing more mental health issues, and we are also seeing a lot of social issues, particularly in areas such as Hackney, where there is high levels of deprivation. People don't know where to go to get help, and they come to their GP for support. We also know that there's a national agenda to get care closer to home, which I fully support. You know, we know that nowadays people see their GP for conditions such as heart failure, diabetes. These would previously been seen in the hospital by the hospital consultants. We are now looking after that in general practice. Finally, we also know that there is a crisis in the NHS. There are waiting times are through the roof, and hospital A&Es are bursting at the seams. And this also has a knock-on effect in primary care. So all these things impact on the demand for general practice, and we have to be honest about it. It means that providing the level of service that we would like to is very difficult, and it is hard for sometimes for patients to access their GP. We don't, you know, it's very difficult for us to provide enough appointments to meet that demand. Saying that, in City and Hackney, we're doing pretty well, and I hope we tried to demonstrate that in the data pack that we provided. I'm very proud of the primary care in City and Hackney. I think that through years of investment, through the CCG in the past, and that current investment continues, we invest in our practices, which mean that we have resilient and high quality general practice across our patch. We try to look at access in terms of 4 different areas, and that was illustrated in the pack. So GP workforce, patient experience, consultation numbers, and other data such as 111 and A&E data. And I would just like to take each one of those very briefly. So the GP workforce, we have higher ratios of GP per 1,000 patients in City and Hackney than the rest of NEL, and we're one of the highest in London. We also have recruited a lot of additional roles. This is other practitioners who work alongside us in general practice, such as physios, pharmacists, wellbeing practitioners, social prescribers, mental health workers, and that's just to name a few. This is a national scheme by which GP practices through their PCNs, which are primary care networks, groups of GP practices, have funding to employ these extra practitioners in the practices. And in City and Hackney, we have been very lucky. We've been able to recruit high numbers of these practitioners, so they're in all GP practices in Hackney. This is been not the case in some areas where they've had real difficulties in recruiting. These additional roles, they help to address the workforce crisis to a certain extent, but they do a lot more. They add so much more to what we can offer patients. They add skills and knowledge and expertise to our teams, and mean that as a GP, I increasingly work as part of a multidisciplinary team rather than as an isolated practitioner. And I think they add so much to the care we can provide for our patients.
Just highlighting page 17 on the members pack. You actually see the graphic there of the because it's quite notable, particularly on the GPs per 100 per 1,000 in Hackney compared to other areas, just for everyone's reference.
Thank you. Also, we look at patient experience in terms of access, and there are many ways we can do that. But I think the easiest way, because it's universal, is looking at the GP's patient survey. And City and Hackney again perform very well in compared to rest of NEL, North East London. also within the country as a whole. And there's a lot of information about that again in the pack. Consultation numbers, again in City and Hackney, we are providing more GP consultations than other areas within the local area, within NEL, but also we are high within London for that also. And that includes face-to-face appointments, where we are one of the highest areas in London for the number of face-to-face GP appointments we're offering. On that note, when I talk about face-to-face appointments, I just want to touch on telephone triage, because I know it's one of the areas that was brought for discussion today. And I appreciate that it's not a perfect system, and it's not. There are difficulties with it, but I think there are also benefits. I think that as a GP, telephone triage allows me to direct patients to the most appropriate services. It allows me to help patients over the phone where it's more when it's more suitable for them. It also means that for those patients I do need to see face to face, I can bring them in for longer appointments. So, for example, if I see a patient who's got multiple complex needs, they don't speak very much English, I can bring them in for a half an hour appointment with me that day, rather than the previous system where I'd have 10 minutes generically for every patient. So I think that is one of the benefits of telephone triage. And then finally, the other area we look at is other data such as calls to 111 and attendances at A&E. And we were looking today at 111 data, so 111 calls within hours, so these are when GP services are open. And again, City and Hackney performed very well on this measure with very low levels of calls to 111 in hours compared to other areas in NEL. And we know that, yes, the Homerton A&E is incredibly busy, but it's actually performing pretty well compared to other A&Es. And I think that is down partly to the investment we have put into primary care, but also to our duty doctor contract, which means that all practices in City and Hackney have a duty doctor, which means that if a patient has an urgent problem that they feel needs to be dealt with on the day, there is a doctor who will call them back on that day and see them if they're needed to be seen, give advice, or signpost them to most appropriate service. And that's not something that's available universally. It's something that's unique to City and Hackney, and I think it has a massive impact on the rest of the urgent care system, and it's why we perform so well in these areas.
Kirsten, can you just explain how you refer to telephone triage and duty doctor? I understand essentially going to be the same thing, but or if they're not, can you just explain how they differ?
So telephone triage applies to all patients accessing primary care for urgent and non-urgent things. And so it's about directing to patients to the right service, having a conversation with the patient and directing them to the right service. Duty doctor is purely around urgent on the day care. So it's patients that feel they have an urgent issue which needs to be dealt with on that day. And they will get a call back from a doctor within 2 hours to give them advice, bring them in if they need to be seen, or signpost them. So it's particularly around urgent access, urgent care. It also means that anybody from other services, so secondary care, can contact a GP and get a call back within 15 minutes. So this might be a paramedic who's at the patient's home, it might be the A&E department, it might be another healthcare professional looking after a patient either in the community or in the hospital. And the GP will call them back straight away to help with that care. And it happens on a regular basis that we'll be able to manage a patient, for example, who has called an ambulance, and by being able to speak to the GP, the paramedic feels safe to leave that patient at home and not transfer them to hospital, which they would otherwise have to do.
And just to explain to members how City and Hackney has this, whereas other places don't, because I understand it's funded through the Confederation.
That's right.
And then presumably the 41 or so practices get extra money through that funding stream to make sure they can employ a duty doctor to fulfil that role.
Absolutely.
And then they are monitored by the Confed as to how they're doing it. Is that
That's absolutely correct. Yeah, that's absolutely correct. So it's an additional contract. And this is about making sure that patients get the care they need, but it's also about, making sure that practices have the resources, and that it helps to explain why our workforce is better than other areas, because it's got the resource in there.
So it's commissioned by the CCG, delivered via the Confederation, and the
yes.
commissioned via the CCG.
Yeah, I've got questions later about the future safety of that in an ICS framework, but I'll come on to that at a later point.
So, I mean, thinking about what else we can do, because we appreciate that, I said a lot about how we are managing things in City and Hackney, but, of course, there are things that we want to do to improve, and we want to work with the GP Confederation, our primary care networks, and ourselves, to think about how we can continue to improve access for our patients and a quality of access as well. We are working closer than ever with our community pharmacy colleagues, and will continue to do so. We feel that we do need to increase the understanding and the awareness in the population around the additional roles and the benefits they have. And that's something that we feel it's important that we need to do. And we need to continue to work with residents, our patients in the practices, to think about how we can make things as easy as possible for them to get the care they need. And I think we have a good track record in City and Hackney of working with residents to think about how to improve services. And of course, we want to continue to do that. So I get to, in summary, the circumstances are really difficult at the moment within the healthcare service, and particularly in what we're talking about today, and GP access. And we have to acknowledge that, and we have to be honest about that. But I think when you see the data, you see that, in City and Hackney, our primary care is resilient, and it is providing high quality service. And we will keep it is top of our agenda. We will continue to work on it and make sure that people who need the care most have got access to that. So I'm going to stop talking now, because I'm open up to discussion and think about some of the things that have been raised and questions that maybe we need to answer.
Thank you. Richard, do you want to add anything, or should we go? Can you just put the microphone on, Richard?
Just a few extra words, if I may. Yes. I'm a commissioner, so I work for the ICB, previously the CCG, and I've been working in City and Hackney for since the CCG began. Just to sort of point out the quality of GPs, we've had no closures of GP practices due to CQC concerns or individual practice concerns in City and Hackney since I've been in City and Hackney, which I think testifies to the quality of the care and the GPs. And that is certainly not the case in other areas in London. Our success around ours, Kirsten said we've been lucky. Yes, we have been lucky, but also we put an additional investment into the PCNs to enable them to recruit the R's staff. So covering third-party employer costs, extra funding for supervision, training, development, etc. All of those things don't actually come with the R's allocation, but they're clearly very, very important. Kirsten's absolutely right. I think we need to do a lot more around engaging with the community about the new model of primary care, because it is not necessarily going to see your GP. There will almost certainly be other members of the primary care team who could meet your needs better, but sometimes it will be the GP who is best, but not necessarily so. I think the additional funding that the CCG and the ICB has been putting into primary care in City and Hackney has made a huge difference. We're putting in at least 40% extra on top of what the basic funding model for primary care is, and we've seen that played out in the numbers, and the GP to patient ratio. GPs are investing that money back into frontline services.
So just to be clear on that, so if you were to aggregate what GPs get under their block contracts or what have you, they actually get in City and Hackney 40% more because of essentially funding through the CCG.
They do. That is to deliver additional services. That's not for nothing. That's to deliver duty doctor and all the range of enhanced services, which ultimately is better for patients because that means they don't have to go to hospital. They can go to their local GP service, which helps with continuity.
Yeah, I think that what we've seen is that extra investment has directly translated into increased workforce, and that's what the numbers show. So that's what those contracts have allowed GPs to do. They're able to employ more GPs, more nurses, more administrators, in order to provide these extra services.
And then lastly, we want to make practices in City and Hackney part of the community as well, not just places to go to when people are sick. So we're currently piloting a volunteers in primary care project whereby we harness the energy of patient volunteers who put on classes for other patients, and also the program supports patients to take up the offer of those classes as well. So really integrating practices in the community. Thanks.
Thank you both very much indeed. I mean, I've got a number of questions, but I think I'll throw it open to members. I mean, I think if we start off, if I can just try and roughly themise it in terms of some areas, obviously access to talk about. I've then got possibly questions on the Confederation, how that interacts with the PCNs, and how things might look under the new ICS structure. But so if we can start off with access, I'll throw it open. Members, can I just to provide some sort of steer? I think that part we come to this item sort of through our collective experiences of counsellors, through casework, through personal experience. If we can try in the way we frame questions not to make it casework asking questions, but pulling out the themes. You know, somebody not being able to get access to a doctor or what have you, or 111, rather than sort of delving into the nitty gritty of individual bits of casework, just because I think that might just sort of assist if we can. So questions, Cllr Adams first, and then we'll go to Cllr Goldberg.
Thank you for your presentation. From my own personal experience, it's been very difficult to see my GP. My surgery kind of closed down, wasting surgery. Maybe you had a wasting surgery in March. For me to register was a problem because I went to the Baffour surgery and filled my form, everything, got there. They start messing me around, and it was very difficult. Eventually, I ended up at loss in practice. So I've been a patient there since March. I don't even know the name of my doctor. I called them at one point. So, you know, I'm on medication. When I called them, my medication needs to be reviewed. I had to wait the whole day before I went to the surgery. When I waited for the doctor to call me back, nobody called me back. I got to the surgery, they asked me to sit down. I sat down. After I had the time to go home. So it's been like, access will be very difficult for me to even see my GP. So somebody that's on medication, repeat prescription medication, even to get it, from my previous surgery, it was automatic. It goes to my pharmacy. I got it whenever it's expired. This time around with my new surgery, it's just like each time when I need it, I need to go back there to request again and again and again, which is time consuming. And not only my only experience, there are other people complaining about that. So I don't know why we have, and I've heard from other surgeries, which are really good, great. Like from, for example, a surgery, she can see a doctor anytime she wants to see a doctor. So I don't know why they're not uniform across board. Why in certain areas it's better and in certain areas it's difficult. I just want to understand why don't we have that cross board in Hackney? That why we have a good service. Good service is not, like uniform across board.
Kirsten, do you want to?
Yeah, I mean, first of all, I'm sorry to, I'm sorry to hear about your experiences. I think that there will always be variability about the way different practices run. I think we have to accept that. I think that with our increasing the number of roles in practices, so all practices now have clinical pharmacists working within them. Some of them have pharmacy technicians. As I said, earlier on, we work very closely with our community pharmacists in individual chemists as well. So there is no reason why there should be difficulties for medication. I think that, working within PCNs, which are primary care networks, groups of GP practices, the benefit of that is that hopefully we're learning from each other and sharing good practice, because I think that's one of the benefits of working closer together. So I know that, as I said, I'm in the North Brotherton Spring Hill practice. We work very closely with two other practices, Stamford Hill and Greenwich Road, and we learn from each other all the time. So I think that what the data shows is generally, as a general rule, we are pretty consistently good in City and Hackney about providing care for our patients. We provide high quality care. But yes, there will be a degree of variability, and practices will do things slightly differently. But we all can learn from each other, and we can learn from good practices, from good levels of care in the different practices. I'm not sure, I hope that answers your question.
No, go.
Yeah.
And Cam.
Just, do you think it's right for me registering with a surgery for roughly about 9-10 months now, not to know the name of my doctor, which I don't even know the name of my doctor. I don't know.
So you should have a named GP, and I am sure you do have a named GP. I agree. It is not. It's not correct that you do not know that GP. I would absolutely agree that you should know the name of your GP. I know that being registered at the Lawson practice means you do have a named GP, because everyone at that practice does have a named GP. But yes, of course, you should know who that is.
But then I guess does this feed into the debate possibly about patient expectation, that means they don't necessarily expect to see that person because of the way you structured the services in terms of, or not? Or is there an expectation that if you have a named GP, that's who you should be able to see? Or is that just a notional name on the file? But when you call up, you're going to see whoever's doing duty doctor that day, or whoever's doing. I mean, what does it mean to have a named GP?
So personally, I'm very passionate about continuity of care, and I do think it's important that people do have a doctor that they know. That doesn't mean they will necessarily see them at every consultation, for sure. And as I said earlier, we are working much more as teams of different practitioners. So I think it's a bit of both. I think there should be one GP who has overall responsibility for a patient. And I think it is important that patient knows who that is. But saying that GP will be working with a range of different practitioners to meet that patient's needs. And I think that's a good thing. I have to say I was skeptical about the additional roles when they first came in, but now working in that system, I see the huge benefits that they bring to our patients.
Thank you. Cllr Goldberg, and then I see online Cllr Samatar and Baffour, but Cllr Goldberg first.
Thanks, Richard and Dr. Brown, for coming. Looking here at the data, per 1,000 people, we have in City and Hackney more than other boroughs. Do we have that data split down to wards in Hackney? And would you say in the north in Hackney that is as well the case? Or do we just have it as City and Hackney in general? And I'm referring to the 3 wards in Stamford Hill.
We certainly can present that data to you by PCN. We could try and map it against ward, but I think that might be tricky. But if you could sort of map the wards on the top of the PCNs, you would get a sense of the GP to patient ratio differential across geographies. Yes.
Okay, thanks. Which leads me to my question, because obviously the data is great. Richard, we've spoken before. I didn't recognize you this time. Took me some time, but yes, welcome to the club. So we've spoken before, and the data is obviously great, and a lot of people's experience is also good. But we have to break it down to access, and then to the kind of service which people get once. But access is a serious issue in the north of the borough. Most people I speak to, and I as a dad of quite a few kids, access, if you call it 8:30, you stay on the line for a long time. You may be lucky and get an appointment, but if you call it 8:50 or 9:30, you don't get an appointment. What happens is the parents either just call the next morning, so that's a whole day that goes through without the child seeing a GP, or they call an ambulance service. I volunteer as a paramedic for an ambulance service, and we get tens of calls a day for kids which should be seeing a GP. So we take them down to the A&E, wait some time to hand over, and a large majority, I don't have the data here, but I did have it, get discharged within a few hours. That's all these kids need, especially kids need, to see a GP. And they're not seeing it, so it's just, then they go to A&E, if they're lucky and their parents are smart enough to call an ambulance service and not to leave the kids at home, be discharged a few hours later. That's a huge drain on the resources, which the Tories are just cutting, so it's just not getting better. But back to my question, I wonder, how does this data work when it doesn't really reflect in what we're seeing on the ground? To an extent, a private company has come into Stamford Hill and has identified it as an area where they can open up private GPs because of the population growth there. They've leased a large space and they have employed 15 GPs to be launched in the next 3 to 4 months. That shouldn't be happening. And if this data is right, how does that reflect that what we're hearing on the ground is not great, and there's 15 private GPs coming, which is great for someone who has some spare capital, but with the crisis and the cost of living, which most people can't, it is an issue. And as a dad, I have to say, when we do call at 8:30, if we miss that 8:30 phone call, nothing you can do. Just wait for the next day. But it's real, and this data, I do wonder if it's correct.
I mean, just building on from that, I mean, what stands out from the GP patient surveys is the Stamford Hill group practice is notably constantly below. I know you'll speak obviously from a Spring Hill practice as well, but which isn't in that situation. But that evidence base there and Councillor Goldberg's experience, what is there a particular issue in the northeast of the borough that's not represented elsewhere?
I think the partners in Stamford Hill would say that they have been struggling, and that was reflected fairly in the GP patient survey feedback, but they are acutely aware of that, and they're doing their best to sort of put in plans to improve the experience of their patient. Some practices do struggle at times. We have the CCG has put money in with the GP Confederation called the Resilience and Sustainability Fund, which is there to help practices in time of need, whether that's because of partnership problems or recruitment problems or any other problems, because a practice can be on a high 1 minute and then down in another minute. Is that variable? Luckily, that's not the case for the majority of practices. The majority of practices are on an even keel. I think the practices in Northeast Hackney are under a lot of pressure from the patient demographic. The number of children per head is particularly high. I recognise that locally. The GP funding formula does recognise high levels of children to a certain degree, but not to the not to the reality of it. So the CCG has put in some additional funding for those practices in the northeast, just out of recognition of the high birth rate, which means that additional number of baby checks that need to happen, additional number of immunisations, all that extra work that really the GP funding formula doesn't, in my opinion, adequately address. So extra help is going into northeast London, but it probably still isn't enough.
Just before I bring Dr. Brown in, Councillor Goldberg, is it that, because I mean, at Lower Clapton, I used to have the same experience. If you miss that 8 o'clock slot, it's gone. That they then moved to far more online accessibility, and you can through that mechanism, I was able so that you were able then to get a call back the same day. I mean, is it that through online portals as well, you're unable to get a same day callback, or is the experience just on the telephone line? And perhaps this goes to different avenues of access. I don't know.
I'm referring to the telephone line, but again, most people that I'm referring to probably don't have access the way that other people. Yeah, but I'm referring to the phone lines.
Yeah, because I mean that is something that I still struggle with as to how we're meeting those two different, if I crudely put them, the demographic that can access online portholes and access, and who are able to advocate, can have a telephone triage and access or get an appointment online, and a cohort of people who are still who are on the other side of the digital divide, who aren't using that. And have we got that balance right, or are there avenues still for access for people who are using more conventional methods?
I think you have to have both. I think that we know that if we can encourage those who can access online, that frees up our phone lines. And I think we should be doing that so that people that don't have access online can get through more easily. I think that's definitely correct. I think we also need to be encouraging our GP surgeries to use better telephone systems. So in our practice, we have a telephone system, as a queuing system, as a callback system. It also allows us to monitor the data. So I know exactly how many calls are coming in. I know exactly how many people are waiting, and I can look at the data. And without the data, without looking at the data, you can't put solutions in place. But yes, it is hard to get through to your GP first thing in the morning. And yes, we would love to provide more appointments. And I would think the majority of practices in Hackney would say the same. But as I come back to the, I'm really honest here, we don't have enough. In my surgery, we do not have enough GPs. I know Stamford Hill would say the same. We are trying to think outside the box, to think about other ways we can operate so that we can provide the best service possible. But we are faced with this workforce crisis, and it's not for lack of trying, and it's not for a lack of desire to employ more people. It makes me very sad that GPs are, there are 15 private GPs coming into work in Stamford Hill because those private companies can pay them more. It makes me very sad. I would love to be able to have 15 GPs working for the NHS. But I don't know what to say about that. It is a real difficulty, and one we're seeing throughout the country.
But can you see, Dr. Brown, can you sort of see in the morning, like, or either on a through the data you're seeing, that look, the first thing at 8 o'clock or 8:30, you're getting sort of 30 calls, and their average wait time is 20-30 minutes, and 15 of those drop off because they don't, and you are able to fit in the first 5 that call, but you're not able to fit in the other 15 that have got through but haven't the other thing. Are you looking at data like that to sort of understand how challenging it is? I mean,
yes.
So what, roughly speaking, what sort of figures are we looking at, sort of from your perspective?
So it's difficult because it's different depending on the patient, the number of patients you have, and I can't tell you the figures off the top of my head, but you do see those patterns. So you do see the first 2 hours in the morning are definitely our business. And we respond to that in our practice by making sure that we do have as many people on the phones during those times. We do continue to encourage people that can use the online portals to use so, and we have you're able to book an online appointment, an appointment with your GP online within 24 hours for those that can. And we are using our additional roles, not just through the PCN, but through our own organisation to try and make sure that we have the best access possible. And it's difficult. I'm talking about my own practice, but I'm sure it is replicated across. So yes, we look at the data. Yes, we try and meet the demand when we can. And we try to make sure people are signposted to the correct services. We try to make sure that people are signposted to community services, community pharmacies, sorry, where possible, because of course they can see many, many minor complaints and are skilled at doing so. And then so yes, I think the answer is we do look at the data and we try to meet that demand where we can.
Go on, Richard, and then I'll bring in the people online.
Thanks. Demand and capacity is largely predictable, and there are electronic tools to help practices understand what's coming through the door or on the phones on any one day. And we've commissioned expert help from the GP Confederation to other practices to help sort of understand their demand and capacity and respond accordingly. I did say demand and capacity is largely predictable, but we have just seen a huge increase in respiratory circulation and respiratory disease. Demand has gone through the roof, absolutely, putting colossal pressure on primary care above and beyond what could ordinarily be expected. And I think in those sorts of circumstances, practices will struggle and patients won't necessarily be able to get through. So it's only sort of predictable under normal circumstances.
Thank you. Councillor Samatar, and then I'll bring in Councillor Baffour. Councillor Samatar?
Thank you, Chair. Just to let you know, I'm having a slight technical issue. So do you need me to put my camera on? Or is it okay if I just do it without it?
It's fine without it. We can hear you perfectly, so carry on.
Brilliant, thank you. And before I ask my question, again, due to the technical things, I couldn't tell you before, with my declaration of interest, I work for City and Mind Hackney as a network wellbeing coordinator. My question is to kind of, I think it was Richard that said this earlier, forgive me if it wasn't, to welcome the suggestion of GPs providing medical but also wider support for the community. And I thought that's a really, really important. On the one hand, later on, my follow-up question would be, how can we support that happening? Because I'm very interested in that. But I also have seen this in practice taking place at my surgery, Nightingale practice, with things like walking group and possible healthy eating groups being organized, etc., which were really, really great. My question is, how is this being kind of communicated to ensure that it reaches the wider diversity of our community? And is the information given in a way that is, you know, kind of acceptable across the different parts of the borough? We've got about 86 plus languages since the last census, and language is always going to be one of the biggest challenges that we have in making sure things are communicated. So I just wanted to kind of touch on that and to see just how that's been engaged. And thank you so much.
Richard or Kirsten?
Thank you very much. So we are incredibly excited about this Volunteers in Primary Care project, which we commissioned a few years ago now. It was delayed due to COVID, but it's now up and running in 7 out of 8 of the initial pilot practices. And we're just going through the governance of getting approval from the ICB to roll this program out further to include another 8 surgeries. I know that it's being delivered by Volunteer Centre Hackney, who are doing a fantastic job, I think. It does sort of, it depends on the strength of the volunteer coordinators, who I've all met and I think are absolutely terrific, but also on the volunteers who come forward as well, particularly volunteers who represent the wider community, because they are best placed to engage with other members of their community. And I know that is happening to varying degrees. So I'm really very keen to sort of see the pilot progress to roll out further. And I think the sky's the limit with this program. I can see it being the foundation for all sorts of inclusive projects, of which there are many. We had a summit yesterday evening. I don't know whether people are aware of it, but it was an Inequalities summit, and we heard about many examples of inclusive projects. And we have Cllr Kennedy there waving the brochure from last night.
And Chair, I will talk about it later in answer to the third of the questions that you've asked me.
Lovely, thank you. I mean, yes, I mean, sort of just going on from Cllr Samatar, I mean, do we sort of have as a city in Hackney, have a sort of strategic plan in terms of the cultural and language barriers, the diversity of the community that we're sort of working through with outcomes?
So we had at our GP enabler group just today, we talked about health literacy and how we can improve health literacy in Hackney, city in Hackney. So it is something we're very aware of, and we are making strategic plans to do. We are in the process of doing so. We had the discussion just today. I think the volunteer project, as Richard says, we are very passionate about it. And this, I think in itself, by working with communities and bringing communities into the GP practice and the GP practice into the community, is a way in itself to help with the health literacy and reaching hard to reach communities. And hard to, I think it's an amazing project. And, at Spring Hill, for those of you who know it, we work in an awful porta cabin. And our patients have created a beautiful garden outside the practice for everyone to enjoy. And in doing so, that they're helping their own health, both their physical and their mental health. And that's just one of many, many examples.
Cllr Samatar, did you want to come back in there, or?
No, just wanted to very quickly follow up on the last question I said about the language, and I really welcome that response. Thank you both. In terms of like the online GP portals, like I don't know if it's across like different GPs or is it just few that I've seen so far. Many people, it's easy obviously to sign online and book your appointments that way. But again, going back not just to language, but also people who don't have access to the computers or might not be, for various reasons, be able to access the opportunity to do that online. It makes it difficult for them to book an appointment or even communicate with their GP. And a lot of people have this issue of trying to get all of their health record, try and understand the data and how they're being kept in different informations that are being sent to them. So again, when we're talking about communicating and engaging communities, it's not just the language, but the different needs of communities vary from so many different aspects. The language is not just people who don't speak English, but understanding requires a lot more than just breaking down medical jargons for a lot of people as well. So that was more of a statement than a question. Thank you, Chair.
No, thank you. And I think that feeds back sort of, with sort of the thing I was sort of asking about before as well, is just, I'm still not entirely sure we've always got it right in terms of, it's great that we've got more online access to meet that need. I'm still not entirely sure for certain cohorts of the Hackney population, the access is the same, and it's how we, I don't know, experiences like that, and Councillor Goldberg's, for people that are still using more conventional routes, and there's not going to be a swift change in that for many reasons. It's how we really tackle
absolutely. I mean, the online access has to be one aspect, and for example, I mean, I don't work at Nightingale, and we talk about Nightingale practice. They use a lot of online access, but they will say, and the partners that work there will say, they encourage online access for those that can use it, but that is so that it frees up their telephone lines for those that can't. And if someone walks into the surgery, equally, they should be able to access the services that way. And I would say the same for my practice. I do appreciate what you say, and I think that we can't ignore that fact. And I think it's something that we have to keep questioning. But the online access has to be one of various ways that patients can access their GP practice.
I see Councillor Oguzkanli as well. I've got Cllr Baffour, Councillor Adebayo, and when we bring in Sally from Healthwatch as well. So Cllr Baffour was next.
Yeah, thank you very much. My point is still around actually what Councillor Samatar said, addressed some of my strategic kind of question I wanted to know, I wanted to find out. But I can recall about over 3 decades that we came into country. Sometimes you'll be there and then your GP will call you maybe in a month or 2 that you haven't been visiting your GP for a while. Then you have to go and make an appointment and all. And it came to a point where you have to walk in for your own appointment and to see a GP and that sort of things. Now it's going into, you have to telephone and make that kind of things. So that means problem is like being addressed as to when and how it gets on. Now, considering the kind of aging population that we are having, migration and external forces, i.e. Ukraine war and that sort of things, and people, the number of population that we have in now, and also a number of deaths, which all statistics are there to support that. What GPs has put forward to the GP kind of the board in terms of like negotiating with the what's it called, the trust, to ensure that issues or problems can be, in terms of long term, can be mitigated in terms of like not having serious pressure and things that will be kind of difficult as we are talking now. Things can be kind of looked into more ahead than waiting for it to happen. Then we try to find a solution.
But sort of, what can we do more on preventative as well, I suppose?
Yeah, yeah, for the long term, in terms of like, yeah, that kind of the issues, considering statistics available.
I think health promotion, health and prevention, and the promotion of good health is vital. And I think within, certainly the system within City and Hackney definitely recognise the importance of that. It's right up there with their priorities. How can we address it? I think that we do it in many ways and have done for a long time, but I think some of the examples are within City and Hackney. We have a proactive care contract, which is another contract via the Confederation, which means that patients with complex problems, whether they are housebound or not, will be called for proactive appointments with their GPs. The majority of these are face-to-face or their home visits. So, for example, our housebound patients will be visited 4 times a year proactively by their GP practice to try and prevent the worsening of health and promote good health. And this is something that's unique to us in City and Hackney. Come back to the additional roles. I think there are lots of aspects, lots of the work done by the additional roles that address this. So, for example, the health and wellbeing coaches who are there to help patients address things that they identify as problems with their health or things that they would like to improve. These are new kind of roles which are just life-changing for those patients that access it. So we talked about the volunteer project. This is a way of using community assets to help people help themselves, help people help each other to improve their health, whether it be through exercise, through social contact, their mental health, or good diet. So those are some of the ways I can think that we like to address. We hope we're addressing those issues.
Thank you. Can I now bring in Sally Beavan from Healthwatch? Sally provides quarterly insight reports, and one of the areas she looks at is experience from GP services. Sally, do you have any observations from what you've heard to add to the debate?
Yeah, I just wanted to add that I think it's very important to think about the trends, because this is the most important issue, I think, of GP access. It's what we hear again and again and again from people, and particularly I think at the moment we're still hearing from people talking about the long wait on the phones. So it's those people that aren't using the digital access, those people that are trying to call, that are finding that very frustrating. But I just thought it was very important to say, if you look back at the overall trends over the last 12 months, it was never going to be a magic one, it's fixed, but we can see consistently people's experience of accessing their GPs is improving. It's slow and steady, and it's not a huge leap up, but it's that gradual move towards people are feeling more positive. Some people are feeling more positive, whereas 12 months ago, it felt like nobody at all was. So I guess I wanted to just say it's not all bad news from our point of view at Healthwatch. We are hearing that, yeah, this is getting slightly better and a little bit better, and if it continues consistently in the way it's going, that's great news, and I think that's quite important to share.
Thanks, Sally. I think we've go on, Richard.
Thanks, Sally. I feel as though we do work very well together, the ICB/CCG and Healthwatch. I know that when I can, I sit on the Healthwatch panel that reviews all of the patient feedback, which is great to look at the individual detail, good or bad. It's quite often a mixed picture, although I would say it's probably more good than bad. And to also sort of discuss some of the background or some of the wider issues that might be related to some of the comments as well. So just and look forward to continuing that working relationship, and that also involves the work that we did together on GP access for people whose first, for people, asylum seekers, and patients being asked for ID that is contractually not required, and the improvements we've seen there.
Thanks. Just before I bring, I mean, is there? I mean, I don't know, for people who are struggling to get through on the phones, is it standard across all 41 or so practices that there's a recorded message saying it's much easier to access online? Have you even thought about, can you support an admin person to support with IT support, for them to call that line to be able to train up? I don't know. I mean, are there ways to try and help train, and because there'll be certain things that will never use the online porthole, but there were certain people who are just having problems, or it's too daunting. I don't know. I'm just trying to think. Are you really every way out of the box? I see Chris has got his hand up there as well.
I was just going to say at the practitioner forum today at lunchtime, they actually introduced a digital inclusion specialist who's now part of the whole PCN network. So the problem is being thought about, being addressed. What's her name? Madeline. Someone has been employed to start looking at that problem.
But I think it's a good challenge, and I think that it is definitely something we should think about. I think that also we should be using, we need to be using our patient participation groups to also talk to our patients about what do they struggle, in an individual practice, what are you struggling with? How could we make things better? How could we make our website better? How could we make our phone lines better? And I think working with our patients who are using our services is the best way forward.
Right, I've got 3 councillors who haven't asked questions, and then I wanted to go, so I'm going to do all 3 in one go. Cllr Adebayo first, then I'll do Cllr Oguzkanli, then Patrick, and if I've got time, I'll bring in Cllr Goldberg at the end. So Cllr Adebayo, please.
Thank you. Some of my question has been asked, but just to know, how often does the GP carry out patient survey to evaluate the service provided? That is one. Secondly, you talk about inclusive projects. Does that include psychotherapists and counselors working closely with the GP? Because some of the mental health issue can easily be addressed by a psychotherapist in order to save money in the long term. Thank you.
Thank you, Cllr Adebayo. Cllr Oguzkanli, I've got those 2, GP survey and mental health at GP. Councillor, and then I'll come to Councillor Patrick. Councillor Oguzkanli.
Thank you, Chair. I'll try to ask a couple of quick questions, if I may. You talked about the crisis in the NHS, crisis in the health service, recruitment, GPs. Obviously, these issues are national issues, and we are having a reflection of that locally. And I think we all appreciate what's been done locally to help our constituents and residents, and it's a great work. Great amount of work has gone into it, and it is still being done. But in terms of national issues, in terms of crisis, the funding issues, in terms of working terms and conditions of NHS professionals, are you of the view that this government is firstly willing, and secondly, and more importantly, capable of addressing those issues? My second question is impact of Brexit on the healthcare professionals. Government was going to take control and then introduce various ways in which professionals from European countries can come to this country to work, highly skilled migrant schemes. Are you aware if those schemes are working, and what impact and what comparison can you make between that and how it was prior to Brexit in terms of having professional healthcare workers working in NHS and local services? And final question, if I may, is do you see that in circumstances that you find yourself as GP surgeries having to deal with some of the issues that you would normally expect a hospital to deal with because of the crisis in hospital, are you having a knock-on effect in relation to some of those issues? Are you concerned about those? Thank you.
Thank you. And then if we can squeeze in Councillor Patrick now as well, please.
No. Sorry. Yeah, one's about funding. I mean, we seem to be quite well funded, from which obviously provides us with quite a good service, according to all the stats. Second in London and certainly first in NEL. I do wonder about the continuation of funding now that the responsibility for funding has been taken away from our local GPs, and I know the council, through Chris and through the mayor who sits on some other board, will continue to fight for City and Hackney, but I am worried that there will be a levelling down in City and Hackney rather than us getting even better. I do think that perhaps patient training, perhaps that's the wrong word, information about the health service and the appropriate people to speak to, because everybody always says when you don't feel well, ring your GP, and perhaps it isn't always appropriate to ring the GP, and perhaps we've got a really good community pharmacy scheme and other schemes, and perhaps people should be helped to understand that they can go to their community pharmacists. Obviously, if they can't help them, they perhaps need to speak to a GP. I do think there's a great expectation out there, I mean, across the country, not only in Hackney, but that GPs, I know in other countries it's the hospital. I've been told that other people, in some cultures, they won't go to a GP, they go to the hospital because in their culture or their country, they don't have GPs. And I've been told in the past, years ago, I sit on the PCT, so I've got some knowledge when I know it's out of date, but people go to the hospital rather than GPs, and that's why hospitals are overcrowded. But I do think there is a need to educate people about other services, to release GP time for those people that really need it. And I don't think I'm glad they've included a digital person's going to be it's been employed, because I don't think the digital stuff is promoted enough. I mean, I could book appointments online, but I've never been told how how to do it or encouraged to do it by my surgery. And people have to feel confident that the surgery will get back to them. I do know someone that said that they tried emailing the surgery through whatever process it is, and the surgery never respond to email, so they've gone back to ringing. So, I think there is a problem sometimes with digital stuff that people don't get back, and that people don't feel confident that their messages are getting through. There is more use of repeat prescriptions. I use my pharmacist. I'm on a repeat prescription, and I just leave it to the pharmacist, and they get the repeat prescription from the they order it from the doctor. All those sort of things could be used more to release capacity, but I'm not really sure that people know about these things. Obviously we need more doctors and nurses and physios and all the rest of it. I think there is some capacity out there for other bits of the health service to take on, but we need to educate people about them, because I don't think they know about them. It's not a criticism of the public, I just don't think they know about them.
Thank you. So number 1, GP survey. 2, mental health support at GP level. 3, is the government capable? 4, Brexit. 5, are you now doing more hospital work? 6, is the levelling down with the ICB? And 7, patient training. Richard?
So I think the first question would, do GPs survey their own patients?
Yes.
Well, there's the National GP Survey run by Ipsos Mori, which is independent, which we all rely on because that gives you comparative data, and that's been running for many years. That's incredibly useful. GPs have in the past surveyed their own patients. I mean, the best way of getting patient feedback is actually talking to patients via the PPG, but it could be done via specific pieces of work as well. They have been asking friends and family tests over the years. I think that was paused during COVID, but is that back, Kirsten?
Yeah.
So that does happen and we have Care Opinion as well as Healthwatch as well, who are great at sort of mining information from online feedback. So there's a variety of sources of patient information.
And the second question in terms of wrapping around more mental health support into GP practice, is that part of the PCN programme?
Yeah, and we have mental health workers who are now based via the PCNs in practices, not psychotherapists specifically, but mental health workers who can help patients with their mental health needs. Also, within neighbourhood teams, we have the mental health neighbourhood teams who we work very closely with in primary care. And so we work with our psychiatry colleagues, our psychologist colleagues, and the mental health workers as well.
And question 3, I'll ask Richard to test your diplomacy skills. Let me try and rephrase it as a slightly less political question. I mean, are there policy initiatives coming down the line from the current government that you think will ease the pressures? I'm trying to make that a bit more politically neutral.
Nothing that I can see. I can just envisage another top-down restructure from whoever's in charge.
And question 4, Brexit. Have you seen a notable impact in terms of recruitment and other factors?
I think there has been an impact within the NHS as a whole. There are schemes for employing overseas doctors within general practice, but there are hoops you have to jump through, which you didn't have to in the past. We are in the process of joining. Well, we have joined up for that scheme. We haven't been able to recruit via that scheme to date.
And following up question 5, are you finding you're doing more work? I think you indicated at the start in terms of diabetes and some heart conditions that was otherwise being dealt with at hospitals, but more broadly as well.
So I would say there's 2 aspects to this. There is the having care close to home, which I fully support, and I think it is the right way forward. So I wasn't saying that I thought that was a negative thing. It was just trying to put some context into the pressures on GP surgeries. I think for many long-term conditions, GPs and their teams are the right people to be managing this. So that's one aspect. The other aspect is waiting times for procedures, waiting times for outpatient appointments in hospitals. I think locally at the Homerton, again, they are performing well compared to some other trusts.
but it no doubt does have impacts on GP surgeries, because while people are waiting for their knee replacement, they need their pain, they need their mobility managed, and that has to happen through the GP while they're waiting their surgery. So generally, yes, it does impact on the care and the, that we can provide our patients, and the demand on our GP practices. Locally, I think the Homerton are doing well, but yes, is the answer.
Richard, question 6, levelling down, and building on Councillor Patrick, is the Confederation at risk? Can PCNs really backfill the work of the Confederation? Bearing in mind the Confed has a borough-wide view. What staffing is primary care going to get under the new ICS structure? You know, your role, you know, is there going to be somebody dedicated looking at knowing the 41 practices in Hackney under the ICS structure? Are we not heading for levelling down?
All those additional sneaky questions there, but I'll try. I'll try and cover them the best I can in as short as time as possible. So the narrative is it is about levelling up. So City and Hackney continues to share what it's been doing in it locally with the ICB in the spirit of sharing, learning, and potentially levelling up if the funding is available. Although I have to say the funding seems to be getting tighter and tighter and tighter. So the reality is possibly something different. However, I'm here, Kirsten's here, to continue to defend City and Hackney and do the best by City and Hackney within, but still mindful of working within the ICB and supporting the other areas within the ICB. The future of the Confederation, confederations do continue to have a future. I think it's likely that the CCG/ICB will commission more from PCNs in the future. That's certainly the national direction, and we will probably be following that locally, but there still remains a space and a function for the Confederation, and part of that is growing into that space, working jointly with the PCNs, and that's already started and will continue to start. I think that's just sort of that's early days for sort of PCNs and the Confederation.
I think yeah, that may be the subject of another a particular item, because I think I probably want to explore that a bit more. And then finally, maybe Kirsten, in terms of patient, you've already touched on it previously, but patient training, more work done there.
I agree with that. I think we do need to communicate with our patients. We do need to educate where we can, and so I would absolutely agree with that. And I think it's something that we do need to think about our comms policy on this, and that goes for educating about where to seek care, when to seek care, who to seek care from, and the multitude of opportunities and services that are delivered through our practices, through other roles.
Thank you. Councillor Goldberg, I'm going to leave because we're overrun by 15 minutes, so I'll make sure everyone had a question. Maybe we can take your question through Jarlath and ping it through after the meeting, because we're already 15 minutes overrun on this item and I want to move on. Thank you both very much indeed. That's really helpful and insightful. We're very grateful. We're certainly I appreciate you're hearing a lot of feedback about sort of access issues, but we don't underestimate the excellent GPs we have in Hackney, and that's testament on the 111 data, on the A&E admissions, and we're very much aware of that. So thank you both for your work. I'm going to move on, and I think we do want to come back to how the PCNs are bedding down, what the role of the Confed is, and protecting the model we've got, and the levelling down question, or levelling up, possibly in more detail, because I think that warrants, in terms of our role as well, in terms of asking questions and exerting, on that subject to protect the Hackney position. So that may be something for another meeting, but thank you very much. We're now going to move on to another item, so I know you're both very busy, so please don't feel the need to stay. So I'm now going to move on to agenda item 5, which is cabinet question time with Councillor Kennedy. We have posed 3 questions, and there has been another one from Councillor Binnie-Lubbock that you notified Councillor Kennedy of, and I'll ask that at the end. Councillor Kennedy, I think the three questions. I think what we'll do is, if I do one, maybe do your answer, open up for questions, and do it that way to break some structure. So the first question is how to protect, which is what we were just talking about at the end there, a local voice for Hackney and a meaningful element of local commissioning within the new ICS. So how do we not just get swallowed up and everything goes off?
Yes, thank you. I will just add a little cheeky answer of my own to Councillor Oguzkanli's question earlier, which is the figure I heard about EU doctors leaving was that we lost 4,000 EU national doctors in this country post-Brexit. And that effectively was the clinical GP level qualification loss that our health service suffered under Brexit. So yeah, your question about how do we keep the local within the ICS? Of course, you ask it rightly and properly, because those hundreds of CCGs that there used to be across the country got shrunk down under the new ICS system into just 42 ICSs across the country, with ours in North East London being one of the 5 London ICSs. A very quick reminder of the structure there at North East London, so NEL ICS level. In charge is an ICB, an Integrated Care Board, which is the final decision maker, meets 4 times a year. Basically, at a fundamental level, it delivers the strategy that is worked up by a wider integrated care partnership. The partnership being a much bigger body with about 40 people on it, including myself. So all the cabinet health leads from the boroughs and the city, all the directors of adult social services, all the directors of children's social services, some representatives from the voluntary sector. So you can see very quickly you get up to a very big board. If you come back down to the borough footprint, what used to be in the very, very old days, the PCTs that Councillor Patrick referred to earlier, that then became the Integrated Commissioning Board, for a while was briefly the Integrated Care Partnership, local ICP, and now the system calls them your place-based partnerships. Our place-based partnership, so at the City and Hackney level, is now called the City and Hackney Health and Care Board. And in fact, we had a meeting of it this morning. So how, amongst all that new system, are we protecting our local voice? Where is our local voice? Well, the first thing to say, Councillor Patrick reminded us of it earlier, is that on the ICB board at the NEL level, it was agreed that there would be a local authority representative in our area, and we were lucky enough to get first dibs to that role. It's on a 3-year basis. So at the first meeting in September, our Mayor, Philip Glanville, was there and is on that board now for the next 3 years. And in terms of what we're thinking about, especially in the future of the PCNs and funding, he is also very helpfully on the Treasury Subcommittee. And in fact, you and I, Chair, have already had sort of like offline discussions with him. So I think we can feel that very much we do have a voice at that level. Also on the ICB, the NEL ICB board, is the previous chair of the CCG here in Hackney, Dr. Mark Ricketts, because he was chosen as one of the 2 primary care representatives. So at that NEL level, good Hackney voice, good Hackney experience. Those meetings of the ICB, as I said, deliver that strategy that is drawn up by the Integrated Care Partnership. That also met earlier this week. We agreed on our draft strategy then. And I will just touch on the 4 core priorities that were agreed at that meeting. And that is babies, children and young people, long-term conditions, mental health, and employment and the workforce. And you'll see in there, with especially reflected by mental health being there, and the babies, the children, the young people, concerns that have already come up and already sit within our own health and wellbeing strategy. So you can see our policy priorities getting reflected at a higher level. Both the ICB and the ICP at the NEL level are public meetings. There are publicly available papers. At the moment, the public are not availing themselves of the ability to attend those. At the moment, they are being held online, but they do want to move to in-person, like your meeting, Chair. And the idea very much is to encourage public attendance and public questions to some of those meetings. You think back to our old CCG, the number of times it got rated outstanding. You think back to what we've just been talking about, the presentations we've had. I think it was eminently clear that the extra funding that we get at this level, at the City and Hackney level in primary care, is reflected in your papers today in the outcomes for our patients. Your worry, I think rightly expressed during some of your questions, is how do we protect that? And in a way, it's the quality of the data that we've got, the awareness within the system that at a City and Hackney level, okay, there may be some more money in primary care, but look at the results that provides. And if you link that into the whole system, I would say the argument, well, certainly I know the argument that I'll be making, and the argument actually that John Geeve, who's the Chair of Governors at Homerton Healthcare, makes, is look at what happens when you invest in what happens outside a hospital to the pressure that you're on inside your acute hospital. Surely that is proving that the funding that goes in at that PCN level is actually delivering and feeding in and giving you a level of protection at your acute hospital level. Recent figures, I would say, back that up. So I can't remember which meeting it was that I've been at during the course of this week, but the figures for the residency of the people attending and being seen in the emergency department at the Homerton have changed from what they normally are, which is normally 3/4 of the people who attend there will be City and Hackney residents. At the moment, their throughput is about 2/3 of people being City and Hackney residents, because they are delivering so much mutual aid to the other acute hospitals in the system that residents are coming from further away because there is capacity at our emergency department. And I would argue, and I think it's a really good argument for us across the piece, including Mayor Glanville in his Treasury meetings, that it's because we're so well funded outside the emergency department that we see that capacity there. And actually what the system wants to do, Richard used it, I've heard it used elsewhere, and it's right, is we absolutely make the argument, you level everywhere up and you give the PCNs across the piece the same level of funding as you get here, and you relieve and you take off that stress from your acute departments. I think that's our argument. And actually, if you want to go to our integrated care partnership papers, where we were looking at our strategy and a diagram that underpins how we see and how we envisage what is happening at the moment, and the structure that we've moved to at the NEL level, it's like an inverted triangle, with at the bottom those boards, the ICB and the ICP, then it moves up and it broadens out into the 7 place-based partnerships, and then at the top, the fruit, the flower of those branches, as it were, is the 47 PCNs.
Is that going to be reflected in the who has the staff?
Well, this is all still up for grabs, and the staffing structure is still being worked through. As part of my notes in answer to this question, I was going to remind you that the structure that we have settled on here is slightly different from the structures that most other place-based partnerships have reached. So to remind you, we have a director of integration at City and Hackney level. The post holder for that is Nina Griffiths. Half employed by the local authority, half employed by NEL NHS. So absolutely a joint system funded post. And then sitting alongside her as the place lead is the chief exec of the Homerton, newly appointed Louise Ashley. That's different from the model that exists in the other place-based partnerships, where for the most part they've gone for one managing director of the whole system. And apparently we had to fight to keep that director of integration post when the NEL system was looking at the staffing structure.
Are you able to say at the moment, say the CCG in City and Hackney had about 28 or 30 members of staff? I asked Henry this at the North East London scrutiny. He wasn't able to give a specific answer at that stage. I don't know whether you're able to, because I appreciate these are live conversations, but how many staff? I appreciate we've got those director levels, but unless they've got people being able to commission and research and think through, be sitting behind them, arguably doesn't mean too much. They need a workforce.
It is
at place.
No, they do, and that is not clear at the moment. And I think, as you often are here, Chair, looking at where you next want to ask questions and who and how you next want people in front of you, I think.
Are we advocating, as a City and Hackney place-based level, that more staff should be residing at place?
We are trying to keep the staff who already know about our place here. We're reaching out to hold them to ourselves. So if you think about some of the integrated teams we've got that work really well at the moment, so our integrated learning disability service, our integrated independence team, we're making an argument that actually we'd like to scope out and develop some more joint commissioning structures and arrangements at the local level. And therefore, as we commission functions across health, adult social care, public health, children and young people's services, at the City and Hackney level, we hold on to those people who know our place as we build on a local integrated commissioning service.
Is it worth just explaining to members? I mean, you know, we've gone from a place pre-CCGs where it was more along sort of an ICS level, PCT level, where there was sort of commissioning from above, but they don't know Durham or Booker Cllr. They don't know the particular geographic. They don't know the 41 practices that Richard Bull knows and who leads them and what their individual issues are. So it's a real issue if the actual decision makers, yes, they may sort of say 80% of the money still comes down to City and Hackney, and that's what it was previously, but you haven't got people with local knowledge. Or you've got somebody, Richard, knowing 41 practices. If you put that across the ICS level, he's not going to know 240 practices if you have a primary care commissioner. So it's a really fundamental, I think, point as to what staff resource is at place and how meaningful place is.
Yes, you're right. And there's some, there are starting to be, I don't know if you, Chair, have seen the Institute for Financial Studies initial work that they did on the ICS. So they did, you know, a quick and dirty sort of study of how the funding was looking, which apparently, is she now Dane, Patricia Hewitt? Has been commissioned to do a much fuller report into ICSs, and apparently what she says may look quite like the IFS Quick and Dirty, which reports the admin costs under ICSs have gone up compared to the total admin costs of the CCGs that they replaced. Now, you could well say that's to do with instituting and the start of, you know, building a new regime, but it's not a good stat, is it? And I think it's about, I think the figure was 12%.
And then I suppose the other issue is what you're sort of saying about how we can make an argument for what Hackney's been doing to others, because the results speak for themselves. Lower 111 calls, the lowest in ICS patch, and lowest A&E admissions. So why don't you rest of ICS copy what we've been doing? Okay, say we win that argument, but where's the scope for then the next level of innovation for us to be able to see that through, and take it then a step further, unless we have meaningful flexibility at place to be able to then take that the next.
So a lot of what Kirsten and Richard were talking about, I think, and a lot of what I want to talk about in answer to question 3 in terms of PCNs and the case studies we had at the Health Inequalities Summit last night, is showing that where you genuinely do things at that neighbourhood, at that PCN level, that work on prevention and that work on anticipatory care. The project that Richard kept talking about is called Better Together, and literally it's Volunteer Centre Hackney using volunteers in GP surgeries where people have their mobility is poor, and they're doing walking clubs, where their nutrition is poor and they're doing cooking clubs. And they're finding, one of the presentations last night, someone who'd been doing the walking club said, we had this woman who was going slowly on a frame to buy her shopping each week. And by the time she'd done the walking club, she was being met in the street, not using her frame, doing the same journey. And that's saving the NHS vast amounts of money by putting relatively small amounts in at the local level. And the more you tell that story, the more it looks like the idea of ICSs and proper integration and bringing things and help as close to people as possible might actually be working. And we're sort of like the model that shows how it's working here.
Members, Councillor Adams? Oh, can you put the microphone, please?
Thank you, Councillor Kennedy. I think if I may start from what we had earlier on about the needs of lack of access and everything like that. So in Hackney, I think, or in our place-based system, we have about 7 neighborhoods. 8, okay. So that's 8. They have different priorities and needs, which is a local issue. For example, like talking about Stamford Hill, lack of access to GP or something like that. How do we work together to make sure that at the ICB level, all those needs kind of marry with their objectives? Because every level, they have different objectives. So all these objectives, how do we just actually ensure that local objectives and needs is being transmitted to the top, where they make all the decision? If that makes sense.
That does make sense. I think there's 2 parts to the answer. One part is about being bold enough to be really specific in each neighbourhood, which is what some of these projects are. And actually, if you think about what we started doing during COVID, our community champions, that's something that has carried on. And instead of just being people from a community who explained what COVID was and what vaccination was to individual communities who they knew, they're now becoming health advocates. And where it works really well, you're getting people to explain what dietary change you might make, where you might access in your community a smoking cessation service, how you might explain within your community why it might be a good idea to vaccinate your children against polio, etc., with people from communities, peer mentoring parents and people with health conditions. That's the first part of the answer. The second part is yes, of course. There's huge things that the NHS absolutely has to provide for all of us all of the time, and you try and pay for the little local bits by using your economies of scale at the higher level. And that's where I think you have to accept that while you're walking club and your cooking club and your primary level mental health might all be delivered much closer to where you are. You might have to work out how you get a bus and another bus and then possibly a train to have your hip hop done on a massive scale somewhere where they're doing hip hops on a huge basis, because they're basic. There's a factory of them, so there's a sort of quid pro quo there. You might have to make a couple of odd longer journeys, but the things that keep you healthier for longer will happen closer to you.
Before we go on to Councillor Kennedy's second question, anything else on Councillor Goldberg?
Councillor Kennedy, you mentioned during COVID the work that the council did, which was led by you. What I would say is it was fantastic, the way you reached out to certain communities. The work was off the charts. I mean, we all know that. So first of all, thank you for that. I went through a lot of the patient surveys, GP patient surveys. They're not here anymore, Richard and Dr. Brown. And maybe it's better to speak here when they're not here. Some of the apart from Dr. Brown's surgery, which is done quite well, the rest of the ones in Stamford Hill, it's almost scandalous. Really, look what's going on here. Almost every survey, it's something from north, from a practice in Stamford Hill. Would the council consider declaring a health emergency in the north of the borough?
Well, that's something to spring on me. I wouldn't. It's all right. I wouldn't advocate the declaration of an emergency without a lot more information in front of me to be able to work out if it was really that bad and things required that kind of declaration. I mean, the first thing I would want to do is get a lot more information from Richard about the help that was on offer to those surgeries that were struggling. I think it was very good that he freely admitted that they knew they were in trouble and they needed help. And I think actually that the fact that they had they all contributed to what's it called, a sustainability fund. That also gave me some sort of comfort. But I appreciate the thrust of your question, Councillor Goldberg, and that is that you can't. It's not acceptable for figures to be that bad for that long in any one community.
It's maybe something we could pick up on.
We do require a bigger response to it.
I've got Cllr Adebayo, and then I'll let Councillor Adams quickly come back in. Councillor Adebayo.
Thank you, Councillor Kennedy. Just one quick question. The better health. How do we promote that to the wider community through the use of GP? I'm talking about the use of our leisure center, because I am a living proof that it does work. If you get involved in physical activities, it helps. So how do we encourage, especially people from ethnic minority, to get involved?
And Councillor Adams, do you quickly want to come back in on?
Yes. Sorry, mine is about resources, resource control. In the past, I don't know, there's different formula before we have the ICB or ICS, whatever. I'm just wondering because in the ICB, I think you have about 7 or 8 place-based or something like that. What is the formula they use to allocate resources to all those place-based? If that makes sense.
Yes, it does make sense. So, Councillor Adebayo, the best sort of like message spreading amongst all our diverse communities is what I was talking about, the community champions, and actually using people from communities like yourself, who are the living proof that lifestyle change can lead to health change, because when people see someone who looks like them and sounds like them and has got better health than them because they've taken an action, they will ask them the question, what action did you take? Or they will copy the action that you have taken. And that is proven again and again in different studies that are done, that peer mentoring absolutely works. Several of the examples last night of projects that worked included peer mentoring and people talking to their cultural and geographical peers. The funding, ultimately, there's still, the jury is still out on A, how much funding is available, and B, how you work out the formulas about how it's distributed. The first bit of funding is that they've had to work up a formula for, is the what used to be called the winter pressures funding, and this year they called the hospital discharge funding. We ended up getting in City and Hackney between us just shy of £2 million. Half of it was done on, I'm trying to remember the exact terminology, an age-based formula for each borough, or was it a population? Half was population based, and then the other half was age based over 50. I'd have to get chapter and verse, but I can tell you, it's in the papers from my meeting this morning. So it's in the City and Hackney Health and Care Board papers this morning, because we had to look at how it was signed off.
The papers to the North East London Scrutiny Commission last month essentially showed the outer London boroughs with the older populations are currently getting extra top-up support over your more demographically deprived but younger boroughs. Now, there's arguments both ways on that as to whether that's fair or not. But, you know, you places like Barking and Havering with massive elderly populations and care home issues with real hospital, they're having hospital issues. So at the moment, we're not getting as much as others. I think that's clear from the data. There's a separate question whether that's equitable or fair, I think. Councillor Baffour, and then I'm going to move on to ask Councillor Kennedy to do the other two together. Councillor Baffour.
All right, thank you very much. Councillor Kennedy, thank you very much for your presentation. But earlier of your presentation, you did mention about Brexit. We lost about 4,000 skilled workers to the NHS, and I'm wondering what would be the circumstances in terms of, like, is it about migration status, or is it about poor contracting or something? And what could have been done differently to keep them, especially as we are struggling to keep good hands?
Not have left the European Union would be the answer to the second part of your question. What would have done differently to keep them? In terms of, I don't know if anybody got round to actually going into the full granular detail of why they left, but clearly it was things to do with confidence of being able, I imagine, of being able to move backwards and forwards, difficulty in visiting friends and support networks in the European Union, envisaging difficulties of movement that were implied by us leaving the European Union, to the extent that they, the vast majority of those people thought that they would have to take themselves and their families, or what parts of their families were in this country, back to their country of origin within the EU.
Councillor Kennedy, can we now take the next two questions together? The second was how to develop and expand home care and intermediate solutions, housing with care, step-down flats, to reduce the growing need for care home places, and the council's role within that. And then the third question was, which you partly already addressed, how PCNs are working for the community to improve primary access care. So if I could ask you to do maybe 4 or so minutes on each, and then I'll open up to questions.
Okay, I will have to cut back a bit on what I have prepared on each of them. I will do that as I go along to the best of my ability. Question 2 looks very much like Manifesto Pledge 193 that this organisation that this current administration was elected on, and I will remind you of that pledge, which was: we will expand accommodation that supports independent living, helping older residents and disabled residents to live independent lives, and helping our care services go further. First important point to make is that in lots of people's minds, you're either at home or you're in residential care. Actually, I think you think of it as being a 4-stage. There are sort of like 4 places, because for about 1,250, 1,300 of our residents, they have home care. They have people who come and visit them in their homes to help them stay at home. Then we have 210, 220 sometimes residents in our own housing with care schemes. And then, roughly speaking, we have about 500, 550, 600 residents who we pay to go into residential care. 2/3 of those are out of the borough, because we only have 4 care homes here. So the thrust of the question is, what do we do? Because we are spending a lot of money exporting people to residential care homes out of the borough. But remember, if you asked most of those people, where do you want to end up living? How do you want to finish your days? Nobody writes down in a residential care home away from where I used to live. So part of the answer to your question, an important part, is to reduce the number of care home admissions that we have in the first place by improving the quality of the care we give at home. So we're recommissioning our home care later on this year. Our housing with care service, that is our insourced housing with care service. Remember, it's only the staffing that's insourced. Very often people go, what do you mean we don't own the buildings? We don't own any of those buildings. There are 14 buildings that housing with care is delivered in, split between 4 registered social care providers. I don't mean registered social care providers, I mean RSLs, registered social landlords. So they're all housing association owned, those buildings. And so we're already looking at how we might make better and more innovative use of our relationships with those organisations. Absolutely crucial to how we answer the question, we'll be working with partners. That is registered social landlords. It is possibly other local authorities. Another vital part of how we deliver that is asking ourselves the very difficult question, and I'll be absolutely honest about this. I think our senior leadership team of officers are more on top and prepared to think about and do this than myself and my fellow cabinet members are, and that is to absolutely interrogate our house building programme and the pledges that we have made as an organisation, for example, to build 1,000 new social homes. We need to be bold enough and challenge ourselves as politicians every time it comes up now to say, where's the supported living in there? Where's the accommodation? The officer cadre are ahead of the politicians on this in Hackney. There might be further work and further questions possibly for you as a scrutiny body to answer that question. And it's something that I think, if I'm completely honest, I was a bit slow to the game myself as a cabinet member for. But none of that will happen quickly, though, and let's also remind ourselves that there are other things we can do. So we can improve the data that we collect and look at exactly what we're going to need, but because any of those projects that we're doing, building more homes, if we've got the data that says this is how much supported living we estimate we're going to need in X years' time, we've got a lot more chance, if we've got good solid data and an argument for it, of being able to successfully win that argument. I think there's scope for assistive technology in homes that will actually allow us to skip some home care visits. When, you know, if I've got up and already, I'm no longer in my bedroom, I visited my bathroom, I visited my kitchen, and I'm in my front room, I'm clearly awake, still alive, and it looks like I've been to the toilet and given myself breakfast. I don't need my home care visit. If I'm still in bed, and my phone says I'm still in bed, I probably need my home care visit to come and help me. Let's, you know, there's chances of using all that kind of technology. We should be embracing it, not be afraid of it. We should be looking at cooperative models, and we should also be looking at ways where, you know, sometimes we forget that you can recover some of your mobility and you can recover some of your independence, and we should be looking at people in housing with care and indeed in some of our care homes and going, can we get you back closer to home? You know, maybe if we work with you, there's mobility that can get you back. So I'll stop there. I'll go on to how the PCNs are working. I've already sort of like proselytized about getting it right. The additional roles that Kirsten and Richard were talking about absolutely is the a key to this. When you talk to doctors, they're always talking about R's roles. How are your R's roles doing? What R's roles? It's the additional roles reimbursement scheme, ARRS. You'll see it coming up in various doctors' briefings, and that's their pharmacists, their social prescribers, first contact physiotherapists, care coordinators, podiatrists, all fulfilled by R's roles. And that's helping the neighbourhoods to work and all those new models of care where things get coordinated at a level that is closer to home for people. It's working at the neighbourhood level on multidisciplinary meetings, anticipatory care, and most importantly, looking at local health inequalities. And so what we've been going on is the sign that we did yesterday. For those of you on the screen, I will talk through what I'm handing out to everyone in the room. But we can I get close to the camera? No, it's all right. I'll do it from here because you need me on mic. But a whole stream of projects at the Health Inequalities Summit last night. Projects, many of which originated and came from the primary care network, and the ones I particularly wanted to point out, I did write down. So page 5 in your booklet, this was a fabulous project that looked at uncontrolled blood pressure, particularly in Black people. So looking at African Caribbean origin people with hypertension. It was PCN practice support that paid for it, and it literally found that if you get people to measure their blood pressure at home, ask them to take some blood thinning medicine, go back to them later, and it was finding out that simple project like that, all done at home, actually outside the practice, was reducing hypertension in Black people in a relatively cheap way. And we know that if you reduce hypertension, you get much better health outcomes. Page 7 is the Together Better program that we talked about earlier. Currently across 7 GP surgeries, and as Richard said, it's going to go up to 16 GP surgeries, all sorts of peer support, getting better health outcomes, again, for relatively small spend at a local level. Page 10, Shoreditch Park and the City looked at nutrition management in sickle cell disease. That was an amazing project that literally said, look, give people with sickle cell some nutritional advice, and it found out you started reducing all sorts of the symptoms of sickle cell disease. And the final one, page 12, the immunisation uptake in the Springfield Primary Care Network. A lot of it actually delivered at Kirsten's practice by her colleague Taseen Khan at the Spring Hill practice. But again, that's PCN based. So how do the PCNs contribute was your question. What do they do to help us out? How are they working for the community? They're working amazingly well for the community, and they are contributing to that success story that you saw in the data for your first item that you had earlier tonight in your meeting, Chair.
Thank you very much. Any questions, Councillor Kennedy, on those two? Councillor Adams?
Sorry, maybe I'm talking too much.
No.
Sorry. So the question is just a concern that, earlier on at the beginning of this session, there were a lot of issues raised or something like that. I'm just wondering or concerned how are these concerns being relayed back to the people that needs to hear them. I know the doctor was here and the commissioner or something like that, but I'm not satisfied that all our concerns was going to go back to where it's supposed to go to. You are the interface here now for us between the PCN and the whatever, the organization. How are we going to be sure that all this concern we raised here today will be relayed back to where it's supposed to go to? Do you get my where I'm getting at?
I mean, yes. Are you specifically talking about the concern because there were individual vox pox concerns in your? Yeah. Okay. The patient voice part of our system at the moment, Healthwatch Hackney is going through, I think it's fair to say, a rough patch. They're recruiting a new chief exec, they're recruiting a new chair, but the commitment to having that voice and listening to that voice has always been part of the system, and is part of the system. And to be absolutely fair to Richard and Kirsten, they will take and carry that away with them. And Kirsten had looked at and seen and read those points that had been made. And Richard, I think the thing he was most pleased to be able to share with us and to hear was when actually Sally said, I can see Sally smiling, said, actually, slowly, bit by bit, our data is showing that more people are getting through on the phone. It's what gives me hope for Cllr Goldberg's question and concerns. But we should always remember and always hold close the fact that we always want performance to improve. We always want performance to get better. And we'll always look at the practices that are at the bottom of the graph, as well as congratulating ourselves about the ones that are at the top.
Councillor Patrick?
Thank you. I support the Councillor Kennedy's proposal about more care at home, and building some step down properties. Presumably, if they are council properties, I do not know why we can't turn some of the properties that we are planning to build into these shared care properties, because they are they're our properties. I know the ones that operate now are housing associations, but they're our properties. I don't think we ever said that when we in our manifesto that building council we said we were going to build council properties. We never said they were just going to be exclusively for families. So I don't see why they can't be for older people or people with disabilities who need that care. I think it's a really good idea, and I think we should start building them soon. I also wonder, we've got a very young population in Hackney and an older population, but also dementia is on the increase. And people with dementia, you can stay at home for a significant time, but often they do need to end up, unfortunately, in a nursing home or a care home. And we do need to realise that and plan for that. And I don't think you can keep some people with dementia at home completely. And I do think we need I just wonder what plans we have for dealing with increased dementia in the population.
I think we do have a dementia strategy somewhere.
Councillor Maxwell gave her apologies this evening for the day. We take that up with her as a separate item.
Yeah. I'm glad you said what you said about agreeing with me about that. I think where we get stuck is there's a narrative out there, which, as I said, I think the officer cadre are more prepared to dent than at the moment the political, the politicians are, which is that, oh, if it's HRA and we're building for our HRA, it must just be straight residential. And I don't think that's the case.
Is there examples elsewhere in the country where they're being more innovative?
As far as I know, yes, where you can as you build for your HRA, you can build much more variety into your stock. Let's be bold about it.
Well, thank you for your being candid about that and about that's an internal discussion. So that's maybe something that we can have as a separate item going forward. Maybe, for example, invite Helen to give her views. Maybe you could even ask Ian to come along, because there may even be quite significant savings to be made for the council in terms of out of borough placements as well. So it could be actually a win-win-win on multiple fronts.
Invest to save.
Invest to save. So it may be that's certainly a specific item we can take forward as a specific meeting, as well as what was raised by Councillor Goldberg in terms of access issues in the northeast and particular issues there, because I think as has been highlighted, the data speaks for itself, as well as sort of the more qualitative feedback we're getting as well. We're at time, so very quickly.
Just very quickly, just about hypertension. Usually it doesn't have any signs or symptoms, and by the time someone is caught with hypertension, it's usually quite late, and there can be, a lot of cardiac issues or renal failure. So I think this is a brilliant, cheap way. Catch them early, save a lot of money. Makes sense. More of that. Thank you.
Thank you, everybody. Thank you, Councillor Kennedy, for some very insightful comments and food for thought for us. So in fact, actually, I think, can I just ask Jarlath, I think 3 things coming out of today's meeting for future topics is the 2 we've just discussed in terms of the house building programme and access in the northeast of the borough, but also the 3rd would be in terms of which I haven't fully followed through with Councillor Kennedy, but I think it's probably more appropriate for Richard, Kirsten and others, is the role of the Confed and PCNs and what that looks like going forward. Members, for the next meeting, what we've got planned is, should it all come off, is the soft servicing contract at the Homerton. So this is where it's porters, cleaners, is currently outsourced. The Barts have brought it in-house in the last year. Thank you for reminding me, John. Homerton's came up 2 years ago. They made some concessions at that stage to greater worker right, but it was still outsourced, with a view that when it came up in the future, they may possibly reconsider insourcing. We are now maybe 2 years off that, but if they mean to do that, now would be the time they've got to start planning. So really just to try and get an update on where we are with that, insourcing soft services at the Homerton. Second topic would be what actions are East London Foundation Trust taking to reduce inequalities in mental health services, and that was something Councillor Samatar raised. A third area is in terms of the money that was announced by the new, relatively new, Minister for Health in terms of discharge funding and what Hackney is doing in relation to that, and what use is being made. And we've also got the 3 topics coming out of today's meeting. And I've just been reminded, I'm grateful for Jarlath, there was a written question from Councillor Binnie-Lubbock, which I'll just read into the record, because I understand it might require more of a written response in due course from Councillor Kennedy. The question was, in all aspects of primary care network, including protecting a local voice for Hackney, can Councillor Kennedy reassure the public that there is a target-based plan to reduce dependence upon and ultimately cease commissioning any social care, health and mental health provider using 0 hours contracts in Hackney? And unless you've got anything else to add, Councillor Kennedy, that's going to involve a written response. Brilliant. Okay, then with that, and I've gone through items for the future meeting. I haven't been notified of any other business, and minutes agreed. Thank you. With that, I close the meeting. Thank you, everybody.
Thank you.